Hi everyone, my name is Ankit, and today I'm with Sarah. We're both medical residents, and today we'll be talking about how to approach a cover call. This video is designed mainly for interns and residents in an after-hours setting. The main objective will be to develop a structured approach when responding to cover calls, including how to prioritize your workload in an after-hours setting. Sarah will now take us through her first cover shift.
On my first day of internship, I was actually allocated to a cover shift. I was actually quite nervous going in because I didn't know what to expect and never been in that situation before. 5 minutes into the shift, I get my very first page. Before I can even finish reading it, comes the second page, and before I can digest what's been happening, comes the third page. At this stage, I feel extremely anxious because I feel like there are 3 competing tasks that are demanding my attention and I'm not sure what to do. One of the things that we hope you'll gain from this video is a method in which to prioritize tasks so that you can make a cover shift a lot easier on yourself.
Part of making a cover shift easier for yourself is to understand your role within the hospital. So first of all, in an after-hours setting, we know there's always a dilution of staff, which means you may be the go-to person for something like 50 or 60 patients. In that scenario, it's very important to know your helpline. That could be your med reg or the surge reg. It's also important to receive a handover from the day teams so that you can discuss any sick patients or any management plans that already may be in place before you arrive. The primary role, since there is a dilution of staff, is the identification and early management, including escalation, for any patients that may be deteriorating. And we'll be going through a little bit of that during this video.
The general flow of a cover call starts with a page. This usually includes some sort of request, usually sent by a member of nursing staff. What should then follow is a phone call, both as a courtesy to the person who sends the page to acknowledge that you've received it, but also so that you can begin gathering more information about what the task may be. This can help guide your prioritization and then will eventually lead to the consultation where you review the patient and deal with the problem at hand. Once you have done so, you can then decide what management may be necessary, which may or may not include escalation in the form of a met call or involvement of senior staff. The phone call itself will give you often a general context of the patient themselves, as well as the problem that they are presenting with at this point in time. What I will say though, that it's definitely not a substitute for actually seeing the patient in person, because you may get a different impression of them over the phone than you would in person.
One approach that Sarah and I have made up completely from scratch is the IBA approach. It's a combination of the ISBAR approach and a couple of things that we've read in books, but essentially we've made it to suit ourselves. And you can feel free to modify it as you see fit. So I stands for identity, P for problem, V for the vital signs and the vital history, A for assessment, which in our case is prioritization, and M for management. We'll go through each one by one. So identity, pretty straightforward. The UR, name, age, and location of the patient. It's also sometimes handy to get the reason for admission, because this can help you put that cover call, that problem that you've been presented with in an after-hour setting, into the general context of the hospital stay of that particular patient. P is for problem, and what I like to do in this situation is to make a headline for myself. Sometimes making a headline is straightforward. For example, the problem might be shortness of breath or chest pain. Immediately, as soon as I'm able to give myself a label, I can start thinking about the differential diagnosis. Sometimes making the label is the hard part. For example, you might be presented with a patient who is a bit more vague or is just not responding appropriately. Maybe you'll give that patient the label of a change in conscious state. How's this useful? Again, it can start helping you develop your differential diagnosis. For example, we might not want to think about metabolic causes, intracranial causes, drug-related causes, or infection. And already you've given yourself a head start in terms of what you're going to ask next. So V for vitals is for vital signs and for vital history. The vital signs are presented here in the ABCD approach. So A for airway, which includes the GCS, B for breathing, the saturations and respiratory rate, circulation for heart rate and blood pressure, and don't ever forget glucose. All of these in total will give you your priority level. Because any patient with abnormal vital signs, or maybe vital signs that are trending to become abnormal, is someone who is deteriorating. Sometimes, even if the vital signs are abnormal enough, you might decide that this patient warrants a med call. I've put temperature in brackets over here because although it's in itself, it's not a vital sign, it can help in the differential diagnosis process. So that's why I've got it here in brackets. What I mean by the vital history is some few key pieces of information that will help you prioritize this particular patient's problem. For example, with the change in conscious state scenario, the simple question might be, is this a new or old problem? And that in itself can lead you to a different feeling about how you're going to manage this patient. So now we'll talk about assessment, which in this scenario would be the priority level of this patient. So for example, going back to the 3 cover calls we had presented before. Let's say patient Johnson is 74 years old. He is admitted after an unwitnessed fall. And let's say he's on warfarin. And now he's been noticed to be more confused. So we'll say that his GCS is 14. Maybe this patient is the first on our list because the thought we have is of intracranial hemorrhage. Then let's say we responded to this patient on 35 South who's complaining of a headache. Let's say that they're 20 years old. They've been admitted for pneumonia. And it's similar to previous headaches that they've had in the past. And they're requesting some analgesia. Maybe this is something we can even give a phone order and review later. So let's say that's number 2. And the last one, maybe we call in and we find out that the IV resite is because of more than 3 days. But the IV site actually looks quite clean. So let's say that could be the 3rd on our list. So this is an example of how to prioritize different tasks. M stands for management. So this could be any early management you could initiate over the phone before you see the patient. For example, getting a blood sugar. Perhaps getting some blood tests if the nurse is able to. Or even doing an ECG, or getting a urine sample, whatever might be appropriate for that situation. So here's a summary of the IBA approach. I've presented it in a linear fashion, but as we know, life is chaotic. Most of the time you'll start off with the P, which is the problem, and then work your way back to the patient details. Never forget to get the vital signs, and also ask a few salient questions to determine the priority of this patient. Think about what you're going to do next. Are you going to go and see the patient early, or maybe you need to do a med call? It's also important to sometimes think about some early management that you can initiate if you have other things that you're doing at the time. So we'll go through a quick example where Sarah will present a scenario over the phone, and I'll be pretending to be a medical resident. Hi, my name is Ankit. I'm the medical resident on call. How can I help you with today?
Hi, Ankit. Thank you for calling back. I've just got this patient that I'm looking after on my shift, and I'm quite worried about him.
Mm-hmm. Can I please start with the patient's details?
Yes, his name's Mr. Johnson.
Uh-huh. And his UR, please?
12345.
And his age?
He's 74.
Yep. And do you know the reason why he's been admitted?
I believe he has had an unwitnessed fall.
Okay. And the last piece of information, just his ward and bed number, please.
He's on 5G,
Mm-hmm.
bed 14.
Okay. So you're saying he's more confused, is that right?
I think so.
Okay. Just before we talk about his confusion, can you please tell me his vital signs?
They're actually quite good. His heart rate is about 78.
Mm-hmm.
I think it was irregular when I felt the pulse as well.
Irregular, did you say?
I think so, yes.
Yep.
His blood pressure is also quite good. It's about 140
Mm-hmm.
on 65.
Yep.
What else would you like to know?
His saturations and a respiratory rate, please.
Yep, he's saturating at 96%.
Yep. On room air, is that?
That's right.
And his respiratory rate?
Yes, it's 16.
And would you have a temperature?
Yes, I did take a temperature. It's about 36.5.
Okay. I'm just going to ask you a few quick questions about Mr. Johnson, just to help me determine his priority. Is this new or old in terms of his confusion?
Well, I think it's new. Honestly, I just met him because I just started looking after him. He's come in today after the fall. But I was handed over that he was completely lucid and was very oriented, but now it's completely the opposite. And from reading his notes as well, I feel as if this is something new for him.
Okay. And is he causing any harm to himself or other people?
No.
Okay.
I'm just worried about him.
Cool. And do you know if this patient has had anything like warfarin or clopidogrel or aspirin?
I do believe he is on warfarin.
Mm-hmm. Do you know what that's for?
Yes, I think it's for AF from what I was reading in the notes.
Okay, that's fine. So, I mean, this patient I think is quite sick. They have a change in conscious state in the context of having a fall and being on warfarin.
Okay.
I'm worried about something happening in his brain.
Mm-hmm.
So I will be there in less than 30 minutes, as quickly as I can.
Mm-hmm.
In the meantime, would you please be able to help me with something?
Yes.
Would we be able to get a urine sample?
Yes, I can do that.
And are you able to take bloods?
No, I can't.
Okay. So I'll come around and then we'll have a chat about what we need to do next.
Okay.
So this was an example of a quick conversation that you can have over the phone. And even in itself, this particular scenario with Mr. Johnson is already anxiety-provoking because how involved it can be when presented with such a scenario. So whenever you're worried about a patient, when you don't know what to do next, it's always important to ask for help. So ask the med-reg or whoever might be supervising, even the ICU registrars if there's no one else around. Thanks for listening to our talk, and we hope you found it useful.